Have you been struggling with your weight for years? Maybe decades, and now you're finally ready to do something. You've tried all the fad diets, and now you're ready to think about weight loss surgery. How do you know which one is best for you? You're just not sure. This video should really help to answer a lot of questions you might have about the various weight loss surgeries. One of the biggest mistakes I see patients make when choosing a weight loss procedure is picking the wrong tool for the job. They have a sleeve because that's what worked for their cousin or maybe their best friend. And the problem isn't that people don't try hard enough to figure out the right surgery for them. The problem is most people are never shown how these options actually compare. As a result, they can feel frustrated and just give up. So today, as a physician assistant with 20 years of bariatric surgery experience, I'm going to walk you through the 4 most common bariatric surgeries, how they work, what the results actually look like, and how to think about which one fits your situation. And be sure to stick around until the end when I'll give you the top 3 questions to ask and why you should ask them when first meeting with a bariatric surgeon. Surgery is generally recommended for those with a BMI over 35 or BMI 30 to 34.9 with comorbidities. Now, BMI is a height to weight ratio. Don't know your BMI? See the video description below where I've embedded a link so you can get yours. Weight loss surgery has evolved from higher risk open operations into some of the safest laparoscopic procedures performed today, with risk profiles comparable to common surgeries like gallbladder or appendix removal. In fact, for many patients, the risks of severe obesity greatly outweigh the risk of metabolic or bariatric surgery. There are about 270,000 weight loss surgeries performed every year in the United States. That sounds like a lot, but this is what surprises a lot of people. Despite being the most effective long-term treatment for severe obesity, the utilization rate for weight loss surgery remains around 1%. That's right. This means less than 1% of people in the United States who qualify for weight loss surgery actually have one performed. Even with the rise of GLP-1 weight loss medications such as Ozempic, Wegovy, Mounjaro, and Zepbound, bariatric surgery continues to dominate as the most durable form of weight loss. In fact, a recent study found that more than half of patients with overweight or obesity discontinued GLP-1 therapy within 1 year, a number that actually grows to 72% by 2 years. This is felt to be due to either price, side effects, or other reasons. Let's talk about how bariatric surgeries work in general. Most bariatric surgeries influence weight in 3 main ways. Number 1, restriction, limiting how much food the stomach can hold. Hormonal or metabolic effects, meaning changing hunger and appetite signaling. Number 3, malabsorption, reducing absorption of certain nutrients or calories. Usually this can increase the amount of weight loss. Not every surgery uses all 3 mechanisms, and that's one of the key differences between them. In this video, we'll be covering the 4 most commonly discussed bariatric surgeries, and here they are. Number 1, adjustable gastric banding, often called the lap band or AGB. 2, sleeve gastrectomy, also known as vertical sleeve gastrectomy or VSG. 3, gastric bypass or RYGB. 4, SADI-S, which is a newer metabolic procedure. Let's get into them. The adjustable gastric band or lap band involves placing a silicone ring around the upper portion of the stomach to create a small pouch. The band is then adjusted by adding or removing sterile saline through a port under the skin during patient follow-ups. This port is usually located somewhere on the abdominal wall. The idea behind the lap band was early fullness and portion control. Average weight loss with this procedure is around 10 to 20% total body weight loss. While it was very popular in the early 2000s, popularity has dropped significantly between its modest weight loss and high rate of complications, including slippage, erosion, chronic nausea, and the need for additional surgery. In fact, about 40% of patients who have had a lap band placed have had them removed and or revised to a sleeve or gastric bypass. Because of this, lap band surgery is now performed far less frequently. The sleeve gastrectomy, often called the gastric sleeve, involves removing about 80% of the stomach, leaving behind a narrow, tube-shaped stomach. This surgery works through restriction, meaning restricting how much food you can eat. And there are some hormonal changes, particularly by reducing ghrelin, which is a hormone involved in hunger. On average, sleeve patients lose about 30% or more total body weight loss over the course of the first year. The sleeve is currently the most commonly performed bariatric surgery and has a strong safety profile. However, it also comes with long-term considerations, including reflux in some patients. It also does not impact the metabolism as much as gastric bypass or SADI-S. This is something I spend a lot of time helping patients think through. And hey, if you're worried you're going to forget all this, don't. In the video description below, you'll find a free printable PDF you can download that summarizes all the points in the video. Next up, the gastric bypass, also known as the Roux-en-y gastric bypass, or RYGB. It's been performed for decades and is often considered the gold standard of bariatric surgery. This procedure creates a small stomach pouch and reroutes part of the small intestine up to that pouch. It works through restriction, hormonal changes, and malabsorption. Although malabsorption is minimal with this procedure. Gastric bypass tends to produce slightly greater weight loss than the sleeve, averaging around 32% or more total body weight loss. Because of these combined effects, gastric bypass often produces significant and durable weight loss, but it also requires dedicated and lifelong nutritional monitoring and supplementation. The SADI-S is a newer procedure that combines a sleeve gastrectomy with a single intestinal bypass connection. The SADI-S was developed to provide strong metabolic effects while simplifying the intestinal anatomy compared to older procedures, such as the more commonly performed BPD-DS. Procedures like SADI-S can produce some of the largest weight loss results, often 35% or more total body weight loss. Though SADI-S can be very effective, it also carries important lifestyle considerations, including possible changes in bowel habits and the need for careful nutritional and laboratory follow-up. This is a must for every patient that has this procedure. Now, here's the critical part. One of the most important things to understand is that no bariatric surgery is easy, perfect, or requires absolutely no effort on the part of the patient. Each option involves trade-offs, and long-term success depends on far more than just the procedure itself, like regular follow-up, self-awareness, lifestyle changes, and ongoing care. The goal is finding the tool that fits your situation, and that's a decision you and your healthcare team can make together. And speaking of your healthcare team, here's those 3 questions I promised you at the beginning of the video. So when you meet with a bariatric surgeon for an initial consultation, make sure you ask these 3 questions. Question 1, what is your specific complication rate for the procedure you think is right for me? And how many of these have you performed? Why is this important? It's crucial to assess the surgeon's experience and the risk-benefit ratio for you. Having a surgeon that's well qualified, well trained, and has experience helps to optimize the outcome for you. Question 2. This is a 2-part question and vital to your overall health and weight loss after your surgery. What does the aftercare program look like for the first year after this procedure is done? And when are labs drawn during this time? You're looking specifically for nutritional support, for instance, a bariatric registered dietitian, and a protocol for checking metabolic and nutritional marker labs. This is especially vital for malabsorptive procedures like SADI-S. Bariatric patients should receive specialized intensive follow-up care for a minimum of 2 years postoperatively, with annual monitoring recommended for life. This may involve a shared model with other bariatric specialists if felt appropriate. This is per ASMBS guidelines. ASMBS is the American Society of Metabolic and Bariatric Surgeons. Question 3. If I don't achieve expected weight loss, or if I regain weight, what are the options with your practice? Why is this important? Are they able to feather in weight loss medications if needed, or refer you to a provider who is trained in these medications? Or do they recommend a revision? Also, is behavioral or psychological counseling offered if emotional issues or coping mechanisms are what's really tripping you up? If they can answer these 3 questions with confidence and a clear plan, you're in the right place. If not, you may want to consider a second opinion. And please, take your time when making this decision. Understanding your options well and taking your time to really think about what's best for you is one of the best ways to reduce regret later. If you're in a place right now where you're trying to decide which option might be right for you, surgery, weight loss medications, endoscopic procedures, or simply want a deeper understanding of the weight loss landscape, consider subscribing to this channel. I post 3 videos a week, and all of them answer questions related to weight loss surgeries, endoscopic procedures, or medications. In future videos, we'll talk about these and other procedures in much more detail, so stick around. I'm Grace, and this is Weigh In Wellness, where I provide safe, thoughtful, and fact-based information on surgical, endoscopic, and medical weight loss. Remember, this information is educational. I'm a physician assistant, but I'm not your PA. Decisions about treatment should always be made with your healthcare team. Thanks for watching, and I'll see you in the next video.